All right. Thank you. Hello, my name's Nick Caruso. Catherine said, I'm a fourth year medical student at KCU, and we'll be talking about the diagnosis of neuromyelitis optica spectrum disorder, NMO-SD, or more colloquially known as NMO. So the Guthrie-Jackson Foundation is a charitable organization that funds research as well as provides materials and patient testimonies regarding NMO. So if you are a loved one or affected by NMO, it's a great place to start with information for medical professionals and non-professionals. So starting with NMO, it's really an interdisciplinary diagnosis. Like Catherine said, I think it should be more a part of the medical zeitgeist, as it's really not discussed much or even at all sometimes in medical school curriculum. And also, I think with the attending physicians, a lot of them have been out of academia for a while and aren't as aware. So it's really talking throughout my clinical rotations there. Uh, there's a lot of people who have never heard of the disease. So of course, it's or as we'll discuss, it's a neurologic disorder. So it touches upon neurology, neuroimmunology. It affects the optic nerve. So we have the ophthalmologist and radiologist diagnose it. But also throughout, the initial presentations of NMO, you'll be seen by a hospitalist, a PCP, a GI, and emergency medicine physician. And considering the pathophysiology of NMO and antibodies produced by B cells, there may even be a role for oncologist. So the study I'm going over is there was an update last year in April 2023 from the Neuromyelitis Optica study group, NEMOS. They put out about 100 pages worth of research about the diagnosis and treatment of NMO, but today we'll primarily be diving into the diagnosis and differential diagnosis. So the methods of this study were the Neuromyelitis Optica study group, NEMOS. They got together at a conference and sat down and discussed NMO and came up with recommendations. Those consist of members internationally, but primarily from 12 German university centers, including Berlin, Hamburg, and Hanover, which are just cities us Americans might be familiar with. And the final report was finalized by 121 members. So what is NMO? It's an immune demyelinating disorder. So aquaporin 4 is a water channel protein found throughout the CNS. And here you can see what aquaporin 4 would look like in the cell membrane. And so NMO occurs when the body begins to produce antibodies against aquaporin 4. And then it results in complement-mediated destruction. Aquaporin 4 is the most common water channel in the CNS. It's located on astrocytes. It's found diffusely, but primarily in the optic nerve, spinal cord, and brainstem, as well as the area postrema. And these anatomical locations end up having a significant role in the presentation of the disease, so it's important to keep them in mind. It's called a spectrum disorder because it leads to a wide range of functional impairment. It's characterized by individual attacks, and the frequency and severity of which can be a variable, as well as the serologic findings can be variable. The etiology is unknown. Like most autoimmune conditions, it just sort of develops in females, and what exactly sets it off, we're not entirely sure. In order to understand the differential diagnosis, you have to think about the history of NMO. In 1868, multiple sclerosis, an inflammatory demyelinating disorder, was first described by Jean-Martin Charcot, or Charcot, I think as we pronounce it in the US. And then in 1992, the first aquaporin was discovered, aquaporin 1. In 2004, they discovered aquaporin 4, IgG. And in 2008, the Neuromyelitis Optica study group was established. In 2014, they sent out their first diagnosis and treatment recommendations, and what we're discussing today is their 2023 update. And here, just to paint a better picture for those less informed about the cells in the brain. So here we have a healthy neuron, which makes up the majority of the brain, and the neuron is covered by a coating called myelin. It's an insulator, and so here you see the neuron and myelin. And then when the neuron is damaged in NMO, the myelin is what is initially damaged. So for the differential diagnosis of NMO, there's multiple sclerosis. Multiple sclerosis is thought to be caused by CD4 positive T cells, but the exact mechanism is unclear. It affects Caucasian females. There's a second disease, which also was kind of in the jumbled mess of, is this NMO, is this a separate disease? But it is in fact a separate disease as well, is a myelin oligodendrocyte glycoprotein antibody associated encephalomyelitis. It goes by MOG and then MOG-EM or AD just stands for the associated encephalomyelitis. But this is caused by B cells and plasma cells, as is NMO. But the difference here we'll see on this graph. Again, we're looking at a neuron. So this neuron is surrounded by the myelin sheath, and the cell that produces myelin is called an oligodendrocyte. So in MOG, the oligodendrocyte is what's being attacked by the antibodies, and then versus NMO, where here we have the neuron, but as well as the blood-brain barrier, and this is an astrocyte here. And so in NMO, the astrocyte is being attacked. So two slight but important differences. And all right, and we'll continue. But so the risk factors for NMO, it affects females, upwards of a 10-to-1 male to female or female to male ratio, the average age of diagnosis, but it can affect children as well as older adults. Late onset NMO, which is characterized by diagnosis after 60 years old, accounts for 25% of cases. Affects people of African descent and non-Caucasian individuals. It affects Asian people as well. There's increased risk with smoking and vitamin D deficiency. They're narrowing in on some possible human leukocyte antigen associations, HLA, but there isn't really anything exactly clear, and it's an area for further research. NMO, the incidence ranges from less than one per 100,000 person years. So if you consider the Kansas City metro of about 2 million people, there should be about 20 new cases diagnosed here every year. And the prevalence, again, it varies, but it's less than 1 to 10 per 100,000 persons. All right. And so the disease course, so NMO is characterized by these individual attacks. So in the initial diagnosis, the patient has no neurologic deficits, but then they'll undergo an attack where the body produces autoantibodies, and these attacks the severity can range from mild tingling to severe paralysis and blindness. The blindness in NMO compared to MS is much more severe, with patients in NMO quickly becoming legally blind and having 20/200 vision. The frequency of these attacks ranges from, it could be as little time as 1 month, and some patients go for over a decade. And with every attack, there's a accrual of disability and accrual of neurodegeneration from the antibodies attacking anatomic structures. So an acute attack leads to long-term damage, which is different with MS, where in MS, it's just a progressive progressive neurodegeneration. We'll talk a little bit more about that on the next slide. And this accrual of disability, where the first attack, maybe you become blind in the left eye, and then in the second attack, you lose loss of function of your right upper extremity. And all these lead to high societal costs, from a loss of the ability to work and family having to contribute to the care of a family member with decreased mobility. The most common cause of death in neuromyelitis optica is respiratory insufficiency. This could come from a lesion to the brainstem, disrupting respiratory centers, or a high cervical lesion disrupting motor innervation to the diaphragm. And also bladder, there can be bladder dysfunction, which may lead to a UTI and urosepsis. The time to diagnosis is very broad. It can take months to years to diagnose a patient, and treatment is best done within 48 hours of an attack. So we really need to get better at recognizing this disease and just being aware that it exists even in order to diagnose and treatment. So this is we're further talking about the neurodegeneration. And so MS and NMO, like I said, they're both characterized by these attacks where you're going through, you're feeling better, but then all of a sudden you have some kind of neurologic deficit. With MS, it's from inflammation. We're not entirely clear, but these attacks happen. And as you see, these gold bars are the attacks and the inflammation. And if you look, so these are separate attacks. And then if you look at the blue graph, which shows neurodegeneration over time, which despite the frequency or intensity of attacks in MS, you will have progressive neurodegeneration, likely due to a process we can't see clinically. But NMO is distinct from this. Here again, we're looking at NMO on the bottom table. But what you see with NMO is there's these distinct attack episodes, but the neurodegeneration is actually stepwise. So you can have these attacks, you get better, but ultimately you do lose loss of function. So in NMO, it's super pertinent to stop the attacks. If you stop the attacks, you stop the neurodegeneration, you stop the disease progression. The clinical characteristics, the three things you need to be looking out for are optic neuritis, transverse myelitis, and brainstem encephalitis, which we'll discuss a little bit further. And then there's less specific signs of NMO, such as supratentorial encephalitis or other neurologic signs. So optic neuritis here, optic neuritis is inflammation of the optic nerve. Here we have a diagram, and here are the eyes. And then the eyes at the posterior part, the back part, the eye produces the optic nerve, and then the optic nerves join each other at the optic chiasm and send visual information to the optic portions of your brain, the optic processing centers, visual processing centers. And so optic neuritis is when you have antibodies that are bound to this optic nerve and are causing damage. So it typically presents unilaterally. It's affecting one optic nerve much more often than both nerves, and it can also involve the optic chiasm as well. So when you're having these attacks, patients experience blurred vision, vision changes such as color blindness, pain, Marcus gun pupil, which is when your pupil doesn't constrict properly, and then papal edema, which is a finding you get from looking into the eye with fundoscopy. But so here's a T2 weighted MRI of the optic nerve. So on the right here, the patient's left, but you see this gray structure. This is a regular optic nerve, but and then here on the patient's right side, but in this optic nerve, you see this area of intensity, which is white, and that is showing inflammation. So because this patient's optic nerve is experiencing inflammation and attack, the visual field deficit will look something like this, where one eye is white, is completely normal, and the other eye is completely blacked out. On this diagram, it's lesion B. And then in this other patient, here we have involvement of the optic chiasm. Once again, we're seeing a gray structure leaving the both optic nerves, or leaving both eyes, and then at the optic chiasm at this X, you're seeing in this white area this increased intensity, and because it's involving the optic chiasm, it may look as a bitemporal hemianopia, where you're losing peripheral visual field, or you could have blindness in both eyes. Right, and transverse myelitis. So transverse myelitis is inflammation of the spinal cord, and the spinal cord, as we know, it carries sensory information, motor innervation. So if a patient is experiencing inflammation of the spinal cord, you can have loss of sensation, loss of motor function, including respiratory and bladder and bowel function, and patients can also experience pain. So here's another T2 weighted MRI. On the left, we have a sagittal image, which is really hard to appreciate the lesion in only one image. And I think so it would be better to focus on this axial image of the patient. So here you have the patient's spine, or the vertebral body, but it's the bone of the spine. And then here you have the spinal cord. And so typically the spinal cord in this view should be a gray circle, as I diagrammed here, but you can see the H-shaped lesion, which is white. So here you see inflammation and fluid in the spinal cord. Right, so this patient has most likely lost some sensation or motor function. And brainstem encephalitis. So the brainstem is I guess the stalk that the brain sits on. It contains the midbrain, the pons, and medulla. And the medulla oblongata is often involved in NMO. And the reason these structures are involved is when they have higher rates of higher quantities of aquaporin 4. But notably in the medulla is the area postrema. It's really, we're not going to see it on this gross anatomical section. But when the area postrema is involved, you get subacute nausea, vomiting, and or hiccups. So if you're thinking about the presentation, we'll discuss this later, a patient presents with nausea and vomiting, and all of a sudden they have an immune demyelinating disorder. It's super hard to catch out in the field. And then this also contains a respiratory centers. You can have bulbar symptoms, where bulbar symptoms being swallowing and talking. Brainstem encephalitis can cause issues with that. And other signs. So the tentorium is another anatomic structure. So supratentorial encephalitis, that really just says inflammation of the brain above this line. And so what that would present as confusion, dementia, altered mental status, and then just a huge lump of neuroscience. The patient could have ataxia, which is difficulty walking, inappropriate antidiuretic hormone secretion, excess sleepiness, a facial palsy. Really, just these are non-specific signs that would make the diagnosis difficult. The lab tests we use. So in testing the serum, there's aquaporin 4 antibody, which is pathognomonic for the disease. It has a super high sensitivity, 95 to 99%. It's a send out lab. So when you do this, it's going to take a week to come back. And when you're trying to treat a patient within 48 hours, that presents a diagnostic and treatment hurdle. And just to emphasize how little NMO is adequately known about in the medical zeitgeist, on the on a website, on the Eurofins website. I guess they're a manufacturer of the test, but they describe NMO as a severe variant of multiple sclerosis, which, as we discussed earlier, it's not. And just a little bit more detail about the aquaporin 4 antibody. So there's cases where you can have presence of it, and there's cases where you can not have. So seropositive and seronegative disease. And seropositive disease, the female to male ratio is 10 to 1. And especially if you're talking about women in their 20s to 40s, the ratio is 20 to 1 during the fertile age. And then if you have a patient that's negative for the autoantibody, it's still a 3 to 1 ratio of female to male, but it affects men relatively more if you're considering just men. You also want to test the cerebrospinal fluid. So once again, more of a pathognomonic thing that's really going to point you towards NMO is a high level of IgG in the CSF compared to the serum. NMO it's not IgA, it's not IgE, it's not IgM, it's IgG. So that can help support your diagnosis. Oligoclonal bands are seen in MS. They're not seen in NMO. So that can be helpful. Glial fibrillary acidic protein, GFAP, that is kind of a research area. It's located in the CSF. It's increased during NMO attacks. And so maybe in the future we can use it to say, is this an acute attack, and help us differentiate patients. And white blood cells and protein will be elevated, glucose might be decreased, but those are non-specific. So if you're diagnosing, so when you're diagnosing a patient, first you're going to think about the core clinical characteristics, the optic neuritis, acute myelitis, area post-traumatic syndrome, as well as maybe some non-specific things like narcolepsy or a cerebral syndrome. And then, so if you have suspicion for it, then you can use this algorithm. So you suspect NMO based on their clinical presentation. You send out the lab, that's the antibody test, but that's going to take 7 days. So you're also going to do a workup, and so you're checking their CSF, you're checking MRI, and you're checking just normal labs, CBC, CMP. With these red flags and alternative diagnoses, they're just kind of, we're trying to get to one disease, so you're making sure it's not that. And then you utilize the IPND criteria for NMOSD. And so this is another, these are diagnostic criteria. So if you're positive for the NMO antibody with symptoms, that will count as disease. But if you're trying to do it in this window period of 7 days when you don't have an answer, you're able to utilize the imaging as well as symptoms to diagnose a patient with NMO despite a lack of lab results. So we'll discuss a case review. So here I have labeled dates, and this is a made-up case, but it's important to write down the time frame of patients' attacks in the HPI, because during the first 2 years of NMO is when you'll be able to characterize attack frequency, attack location, and attack severity. So, patient's first attack, they had optic nerve damage. Most likely the next time they experience an attack, it's going to be the optic nerve. And then we want to know, was that a year? Was that 6 months? And so you can characterize the disease. But so to get into it, so 63-year-old female presented with nausea, vomiting, and hiccups. Her review symptoms was otherwise normal physical exam, past medical history of lupus, hypertension, diabetes, a little bit of kidney damage, chronic kidney damage, and then glaucoma. Her labs were normal. Her CT, abdomen, pelvis showed a possible whirlpool sign, which is kind of a non-specific sign, but it could mean a small bowel obstruction. Then they did an EGD as well, and they saw some ulcers. It was negative for H. pylori. But ultimately, the patient's symptoms resolved while she was admitted. So they just gave her a diagnosis of, I guess it was H. pylori, because it wasn't a small bowel obstruction. I guess it could have been gastritis. And then the patient was discharged on antibiotics and PPI. And during this time, the daughter of the patient noted worsening memory. And then come to September 2022, the patient experienced acute vision loss described as wavy color changes. And so she saw a retina specialist, and he took a look into the patient's eye. And because she has diabetes, the patient would have had cotton wool spots, these white areas, and then increased proliferation of the vessels. And so here, these dark red lines are the vasculature of the eye. But and then the retina specialist said, oh, I think there was a hemangioma or a tumor in the setting of diabetic retinopathy. So he administered chemotherapy to the eye. And so, while yes, maybe he saw that, I don't think that necessarily a a tumor or hemangioma could have accounted for the patient's visual loss at this time. So if there was a isolated lesion like we see here, if you compare that to the visual field deficit, it would be more focal to the area. But to, I guess, one area, as we see here, this gray dot would be a lack of vision there. But really, the patient was having monocular vision loss as well as some bitemporal hemanopia. So I don't know, it doesn't really, I guess the symptoms didn't line up with the diagnosis of a tumor hemangioma from the retina specialist. And so then the patient went, had follow-up with an ophthalmologist, a general ophthalmologist who does general and cardiac. So he took a look at the patient's visual field and said, I have no idea why this person would think there was a tumor hemangioma, or which there could have been, but if you're talking about the vision loss, it absolutely didn't correlate to that. So this ophthalmologist got stat MRI. The patient was admitted to the hospital and diagnosed with NMO. There was right optic nerve and optic chiasm involvement. So it would be kind of a mix of these two visual fields. The aquaporin 4 was confirmed later. Plasmapheresis started and vision returned over 4 months. So to discuss the treatment, that would be a whole, of the 100-page paper that was put out is about 70 pages. So it's a whole nother subject. So during an NMO attack, here's an algorithm, but to simplify it, you want to start plasmapheresis early, give 5 to 10 cycles. From the time of symptom onset to plasmapheresis, if it's done between 0 and 2 days, you have 40% of patients have complete remission, but if it's delayed 7 days, only 3.7% have remission. So super pertinent to do this quickly. And then you also administer steroids. With chronic treatment, once again, it's an algorithm. There's about 4 major monoclonal antibodies we use. Which we'll discuss shortly, but here you can see them: eculizumab, ravulizumab, inebilizumab, rituximab, satralizumab. And so we've had these 4 drugs for several years, but there's been no head-to-head study. And then the FDA did a study, did a network meta-analysis to compare. So for chronic treatment of NMO, what the FDA found was eculizumab/ravulizumab, which operate via complement inhibition, and for ravulizumab is a long-acting form of eculizumab. So they're the same drug, just different. They're different release times, but so they found that eculizumab and ravulizumab were 90 patients treated with it were 90% less likely to relapse compared to satralizumab or inebilizumab. And those 2 drugs were through B-cell depletion. And then there's also a role of interleukin-6 receptor blockade with tocilizumab. But really, the take-home message from this slide is complement inhibition is generally the best drug, although it's a very, choosing the right treatment's a very complicated process. And so the key points, neuromyelitis optica is not multiple sclerosis. NMO is caused by AQP4 IgG antibodies, which mediate the disease process. These preferentially target the optic nerve, the spinal cord, and the area postrema. The accrual of morbidity occurs with each individual attack. It's a stepwise process. In the acute phase, you treat patients with steroids and plasmapheresis for chronic treatment, generally eculizumab, ravulizumab, although that's a little bit more of a nuanced conversation than that. And so here are my references. And does anyone have any questions?